Welcome to Sport Safety International's Sport Safety Risk Management Series, Course 6. This is Module 3, Conservative Management and Prevention of Ankle Sprains in Athletes. The mission of Sport Safety International is to promote injury prevention and safe participation in physical activity and sports by providing the highest quality educational programming to athletes, parents, coaches, and sports medicine professionals. This course will review the recommendations of the NATA position statement, Conservative Management and Prevention of Ankle Sprains in Athletes, published in August 2013 in the Journal of Athletic Training. Upon completion of this course, learners should be able to describe common injury mechanisms and musculoskeletal physical examination techniques necessary for accurate diagnosis of acute ankle sprains. Determine the need for imaging of ankle sprains through the use of the Ottawa ankle rules. Describe basic treatment and rehabilitation strategies for ankle sprains. Discuss return to play considerations for those who have suffered an ankle sprain. Describe prevention strategies for reducing the incidence of ankle sprains. Discuss special considerations for associated ankle injury, including high ankle sprains, associated fractures, and osteochondral injuries of the ankle. Describe common factors associated with chronic ankle instability and strategies for reducing episodes of instability. Ankle sprains are common injuries that affect athletes of all ages and in all sporting activities. There are an estimated 28,000 ankle injuries that occur in the United States each year. These injuries translate into an enormous burden on the healthcare industry and result in hundreds of millions of dollars spent on treatment each year. In sport, ankle injuries are the most common injury reported, with some estimates attributing upward of 45% of all athletic injuries to ankle sprains. Sports with high incidence of ankle sprains include field hockey, volleyball, football, basketball, cheerleading, ice hockey, lacrosse, soccer, rugby, track and field, gymnastics, and softball. Most ankle sprains result from damage to the lateral ligament structures, which include the anterior talofibular, the calcaneofibular, and the posterior talofibular ligaments, after a stress on an inverted and plantar flexed foot. The clinician begins physical examination of the patient with an acute ankle sprain by asking about prior history of injury. A previous ankle sprain is the most common predisposing factor for a recurrent ankle sprain. The clinician should try and determine the mechanism of injury, which may provide insight into which anatomical structures may be damaged. Clinicians should observe obvious deformity, swelling, discoloration, and ecchymosis. Palpation of key anatomic structures should be utilized to note pain. Special tests should be utilized to determine the presence of pain and joint laxity. Functional testing is valuable, and clinicians should observe patient function or lack thereof following ankle injury, as this may be important for determining the need for radiographic review. Additional imaging may be recommended by a physician in order to provide better clarity as to the extent of ankle injury. The mechanism of injury may provide valuable information as to the anatomical structures that may be injured. The most common mechanism of injury is inversion, which frequently occurs with a component of plantar flexion and hindfoot internal rotation. Inversion injuries will most frequently cause injury to the lateral ankle structures, but may also cause injury to the ankle syndesmosis with repetitive injury. Clinicians may also note medial side tenderness, which may result from impingement or bruising of the medial structures with extreme inversion. Eversion is less common as the fibula extends more distal, helping to resist this motion. Eversion may result in injury to the medial structures of the ankle. External rotation, hyperdorsiflexion, and hyperpronation may cause injury to the ankle, says syndesmosis, which will result in symptoms above the talocrural joint. Common mechanism of injury in sports include stepping on another's foot, landing from a jump, stressing of the foot in a fixed position, trauma at heel strike, and twisting on an uneven surface. Observation of the injured ankle can provide valuable information to the clinician as to acute injury frequently causing swelling that is very distinctive to the injured anatomy. Clinicians should look for obvious deformity, swelling, and discoloration, which is often more apparent during the days following the initial injury. Clinicians should palpate the involved anatomy and note tenderness, crepitus, and extent of edema. Individual ligaments on the medial and lateral sides of the ankle, as well as the ligaments that support the syndesmosis, should be specifically palpated. Bony anatomy should be palpated at various points along the bone. The tibia and fibula should be palpated around the malleoli as well as proximally along the lower leg. Clinicians should be alert for associated bony tenderness that may indicate incidence of fracture. A squeeze test at mid-calf may be helpful to identify lower leg fracture or syndesmotic injury. The proximal fifth metatarsal, talus, and calcaneus are areas that may be secondarily fractured with ankle injury. Tendons should be palpated along their course across the ankle joint. Special tests should be utilized to identify ligament injury and joint laxity. Special tests for the lateral side include the talar tilt test, anterior drawer test, and the cotton test that may identify lateral laxity. Medial side tests include the cotton and Kliger tests. Special tests for the syndesmosis include the modified Kliger, which involves dorsiflexion of the ankle and external rotation, cotton, fibular translation, and squeeze tests. Surprisingly, few authors have evaluated the diagnostic accuracy of special tests to assess the most commonly injured ankle ligaments. The gold standard for ligamentous injury has been observation of such injury during surgery. Sensitivity for the anterior drawer test, the most common test to assess the ATFL, has been reported to range from 32 to 80%, while specificity has only been reported in one study. Diagnostic accuracy of the talar tilt test has been reported in a single study with sensitivity of 52%. Specificity has not been reported. Diagnostic accuracy of the Kliger, cotton, squeeze, and fibular translation tests have received little attention. Positive drawer test 5 days after injury is more sensitive and specific than examination performed within 48 hours of injury. Clinical exam prior to the accumulation of swelling may be more beneficial than after, but accuracy has not been determined. Clinicians should be vigilant and assess all associated lesions. Functional tests like bearing weight, progressing to a toe raise, to hop and balance testing may help to clarify the extent of injury. Being able to walk greater than 4 steps following injury or being able to hop from their toes without their heel touching the ground are both important functional findings. Ankle injury is graded based on severity, as ankle injury may include a spectrum of injury and disability. Mild grade 1 injuries generally involve minimal joint laxity and disability, while severe grade 3 injuries involve ligamentous laxity and significant dysfunction. Radiographs are ordered for 80 to 95% of patients who present to the hospital emergency room after foot and ankle trauma. Yet only 15% of these patients actually have bone fractures. The Ottawa ankle rules were developed to reduce the unnecessary use of radiographs in patients with ankle sprains. The Ottawa ankle rules state that radiographs are necessary only when pain is present in the mallear zone and the patient exhibits any of the following findings: bone tenderness along the distal 6 centimeters of the posterior edge of the medial and lateral malleolus, bone tenderness directly at the tip of the medial or lateral malleolus, bone tenderness on the middle third of the malleoli, inability to bear weight and walk 4 steps immediately after injury or at the emergency department. Radiographs of the feet are indicated with pain in the midfoot zone and any of the following findings: tenderness over the navicular or base of the 5th metatarsal, inability to walk 4 steps following injury. The OAR have been extensively studied for accuracy in predicting the presence of fracture in ankle and midfoot. OAR demonstrated nearly 100% sensitivity, but specificity was quite variable, ranging from 10 to 79%. The missed fracture rate was 1.4%. Most studies to evaluate the accuracy of the OAR have been done with emergency department patients. No studies have been published utilizing the OAR by certified athletic trainers. Other fractures can accompany inversion ankle injuries. Fractures of the anterior process of the calcaneus are caused by an avulsion injury of the bifurcated ligament, which may occur with forced inversion. The lateral talus, the attachment site of the posterior talofibular ligament, and the proximal 5th metatarsal can also occur with inversion. Several diagnostic imaging techniques are also available to assess ligaments after ankle trauma. The purpose of advanced imaging is to determine the exact location and severity of injury. However, imaging studies that evaluate ligament integrity have questionable value in assessing acute injury because treatment decisions and outcomes are not usually influenced by the results of these studies. Stress radiographs have long been used to diagnose mechanical instability of the lateral ligaments of the ankle, but the reliability of these measures are questioned. Radiographic measurements of anterior drawer and talar tilt tests show low sensitivity of 36 to 50%, but high specificity of 100%. Stress radiographs are not reliable enough to make the diagnosis of ligament rupture, regardless if mechanical devices or local anesthesia is used. Ankle arthrography and peroneal tendography have been used in the past, but due to the invasive nature of the procedure and the lack of direct visualization of injured ligaments, there has been decreased use of these procedures. The preferred imaging technique to determine or detect ligament rupture is MRI. However, the accuracy, sensitivity, and specificity of MRI is inconsistent, particularly when acute injury is compared with chronic ankle instability, or CAI. MRI is also useful for demonstrating any associated injuries that may delay complete recovery, such as osteochondral lesions, which are prevalent after inversion injury. MRI is very expensive, so it is often not utilized acutely. Use of diagnostic ultrasound has gained popularity lately because it is portable, less expensive, and provides immediate dynamic images for interpretation. However, accuracy is highly user-dependent. The gold standard for identifying the extent of ligamentous injury is intraoperative inspection. Osteochondral lesions of the talus, or OLT, is a defect of the articular cartilage and underlying calcaneus bone. The cause has been debated, but there appears to be a strong link with inversion injury. A comprehensive review of OLT showed that 76% of patients reported trauma, 56% of lesions were medial, and 44% were lateral. Those who developed sequela from inversion injury had an incidence of OLT between 38 and 81%. Similarly, those who underwent surgery for lateral ankle instability demonstrated 17 to 63% incidence of OLT. Plain radiographs often do not reveal the presence of OLT. MRI and CT both offer advantages for imaging OLT. Strength of recommendation taxonomy, or SORT, is utilized to evaluate the strength of a recommendation. Recommendations should be based on the highest quality of evidence available. SORT will be utilized to evaluate the quality of the recommendations that are made based on current published literature in order to provide the learner with the most up-to-date perspective of the strength of recommendation. Level A recommendations are based on consistent and good quality patient-oriented evidence. Level B recommendations are based on inconsistent or limited quality patient-oriented evidence. Level C recommendations are based on consensus, usually practice, opinion, disease-oriented evidence, or case series for studies of diagnosis, treatment, prevention, or screening. Level 1 studies are of the highest level and utilize good quality patient-oriented evidence. Level 2 studies are of limited quality patient-oriented evidence, while Level 3 studies offer other evidence including guidelines, extrapolations from bench research, usual practice, opinion, or case series. Published studies may contain consistent conclusions or inconsistent conclusions, which show considerable variation among studies' findings. Scrutinizing published research for quality and consistency help to clarify the strength of recommendation that is made based on the published research. The value of recommendations for diagnosing an ankle sprain are as follows. Gathering a patient history is important, provides valuable insight. However, severity is difficult to determine. The evidence to support this recommendation is Category C. Assessment of range of motion can provide insight into injury to ligaments, muscles, tendons, and nerves. The evidence is Category C. Utilization of special tests to assess injury to lateral ankle ligaments, such as an anterior drawer or talar tilt test, performed soon after the injury and before joint effusion has accumulated, may have better diagnostic accuracy than tests performed after effusion has occurred. The evidence for this is Category C. Special tests such as talar tilt and anterior drawer have more diagnostic accuracy 5 days after injury than they do 2 days after injury. The evidence for this is Category B. Special tests for seismotic injury, such as the squeeze, cotton, and external rotation test, should be performed to assess injury to the anterior inferior tibiofibular ligament. And this is also a Category C evidence. The Ottawa ankle rules are a valid clinical tool to determine the need for radiographs of the acutely injured ankle or midfoot and is characterized as evidence of Category A. Stress radiography is unreliable and is evidence of Category B. MRI is a reliable technique to detect acute tears after acute injury. Osteochondral lesions of the talus can be detected by both MRI and CT scan. Compared with MRI, diagnostic ultrasound is useful but less accurate and sensitive in detecting acute lateral ankle ligament injuries. After acute trauma, MRI has high sensitivity, specificity, and accuracy to determine the level of acute injury to ankle syndesmotic ligament injuries. Arthrography and tendography are less accurate than MRI and CT, especially when performed 48 hours after lateral ligamentous injury. What is the optimal treatment in the management of lateral ankle sprains? Rest, ice, compression, and elevation, or RICE, is almost universally accepted as best practice by athletic trainers and other healthcare professionals immediately after acute ankle sprains. The acute phase of injury is defined as the period of time of injury until the signs of inflammation, which are pain, heat, swelling, redness, and loss of function, peak and then begin to diminish. The subacute phase of injury occurs as the body shifts from inflammation to the proliferation stage, which is characterized by new collagen and capillary formation. The goals of acute care are to protect the injured ankle from further injury, control pain, limit swelling, and reduce the secondary hypoxic injury that results from the acute inflammation reaction. In spite of this near-unanimous clinical consensus, limited evidence from high-quality randomized clinical trials supports the use of these interventions. Most of the rationale for using RICE, or individual components is based largely on low-quality clinical trials and laboratory studies with uninjured participants or animal models. Utilizing cryotherapy has been shown to reduce nerve conduction velocity, causing analgesia of the skin, curbing swelling formation, and decreasing metabolic activity and subsequent secondary injury in laboratory and animal studies. Strong clinical evidence for advocating cryotherapy is limited, and there is no evidence not to apply it. Cryotherapy can be applied in a variation of models using ice packs, water immersion, frozen ice cups, chemical cold packs, sprains, and commercial units, which are popular among clinicians. In addition to the various modes, there are differences in duration of treatment and rates of reapplication, and they are highly variable. Currently, the optimal mode, duration, and frequency of reapplication have not been established. Caution should be used when applying chemical cold packs. The below freezing temperature and direct exposure to the skin can cause tissue damage. Although the clinical evidence is sparse, cryotherapy has been a mainstay of clinical practice for rehabilitation specialists. Compression of the injured ankle is used to control swelling during acute and subacute phases of injury, and it is applied in a variety of modes, including elastic wraps, adhesive tape, commercial braces, and units that apply simultaneous cold and compression. Acute inflammation increases the permeability of capillary walls, which allows fluid to escape the vasculature and enter the tissue spaces. Applying compression against the skin over the injured tissue controls hemorrhaging and is thought to increase the hydrostatic pressure at the injury site and counteract the increased osmotic pressure resulting from the injury. As with cryotherapy, limited evidence from high-quality clinical trials supports the use of compression, and minimal research supports the advantages and disadvantages of one mode of compression over the other. There are no published reports on the detrimental effects related to the application of compression after acute ankle sprain. Although compression has near universal acceptance, limited research and conflicting results make it difficult to provide specific treatment recommendations. Electrical stimulation, in particular, high voltage pulsed current, or HVPC, is a common adjunct to RICE in the acute and subacute phases of injury, in part to control edema, because they believe that in doing so eases acute symptoms, which may in turn affect the rate of recovery and normal function. Even though HVPC reduces capillary permeability and curbs edema formation in animal models, data for human studies do not support this intervention or other forms of electrical stimulation in managing ankle sprains. Traditionally, thermotherapy has not been recommended for acute management of ankle sprains, given the widely held empirical belief that heat increases swelling and blood flow and exacerbates the injury. Use of contrast treatment, which is hot, cold, and then hot again, on subacute ankle edema was reported to have no effect at all, and all interventions increased limb volume, but the most significant increases were with warm contrast therapies. As a result, thermotherapy is not recommended due to the lack of quality research needed to make a clinical recommendation, either for or against the practice. Thermal ultrasound therapy has been used by clinicians for a variety of soft tissue injuries to reduce pain and increase range of motion. Yet the literature does not support the use of ultrasound in managing ankle sprains due to the lack of high-quality clinical trials. Strong evidence indicates that non-steroidal anti-inflammatories used during the acute and subacute phases of injury decrease pain and improve short-term function after acute ankle sprains. Concerns exist that the analgesic effects of non-steroidal anti-inflammatories might allow athletes to return to activity before the actual healing process was complete. Non-steroidal anti-inflammatories may result in reduced strength of the healed tendons and ligaments and may, therefore, make those structures more vulnerable to future injury. In addition, gastrointestinal irritation is common with nonsteroidal anti-inflammatories. Adverse effects and other medical concerns must be factored into the decision to utilize these medications in the treatment plan for lateral ankle sprain. Topical nonsteroidal anti-inflammatories have been effective in reducing pain and improving function in patients with ankle sprains and other soft tissue injuries. These topical treatments in the form of gels, creams, and sprays are applied or massaged over the injured site and can be reapplied several times during the day, depending upon the type of medication. The major advantage of topical nonsteroidal anti-inflammatories are their effectiveness in reducing pain without systemic side effects. Alternative medicine that has purported anti-inflammatory effects may be of value in managing ankle sprains and other musculoskeletal conditions. Comfrey, a flowering herb purported to have anti-inflammatory effects, was utilized in variant concentrations in cream and gel and has shown favorable results and improved function. Growing acceptance of alternative treatments and patients' requests for these interventions warrant further investigation. Standard of care for grade 1 and grade 2 lateral ankle sprains is functional rehabilitation, which consists of ankle stabilization via the use of an elastic bandage, bracing, taping, or external support with progressive weight bearing and exercise. Studies have shown that patients who underwent functional exercise had less pain and returned to functional activities sooner than those who underwent immobilization. There is compelling evidence for bracing and functional rehabilitation in the management of grade 1 and grade 2 lateral ankle sprains. For grade 3 lateral ankle sprains, clinical consensus suggests that some form of immobilization is necessary, although the best type and duration of immobilization are currently unknown. Like grade 1 and grade 2 sprains, grade 3 sprains are frequently managed by functional rehabilitation. Although the studies favor the use of functional rehabilitation in the short term, long-term results are seldom reported, and sequelae are common. Surgical intervention is indicated when functional rehabilitation has failed and patients have chronic symptoms. Secondary reconstruction of grade 3 injuries is possible even years after the initial injury, and outcomes are similar to those for primary repair. Therapeutic exercise or functional treatment includes interventions to restore range of motion, strength, and sensory motor function, which may be impaired after injury. Currently, best practices for management of ankle sprains includes exercises and mobilization techniques to restore range of motion and strength to periarticular musculature and balance training to restore function and reduce risk of re-injury. Concentric and eccentric strength deficits for the ankle everters, inverters, and plantar flexors have been reported in the literature, both after acute injury and in patients with chronic ankle instability, reinforcing the need to strengthen all muscles around the ankle after lateral ankle sprain. The peroneal muscles may be injured with an inversion sprain, resulting in decreased motor recruitment initially after injury and leading to secondary loss of eversion strength. Acute ankle inversion trauma has also been reported to impair peroneal nerve function. Trauma and effusion may cause inhibition of motor function. Concentric and eversion defects have also been associated with patients who exhibit functional ankle instability. Eccentric muscle actions may enhance joint stability by providing an antagonistic force that resists joint translation. Contributing factors for debility include both muscular strength and neuromuscular control. Therefore, a stronger muscle group has a greater ability to promote joint stability. Ankle strengthening exercises are universally performed as part of a comprehensive rehabilitation program. However, the optimal mode and intensity of exercise used during rehabilitation are unknown. Clinical consensus suggests both open and closed chain exercises in a variety of modes should be performed to enhance muscle strength. After an ankle sprain, ankle dorsiflexion range of motion may be impaired, which can lead to functional limitations in gait and contribute to functional ankle instability, or FAI, and re-injury. Clinicians often recommend various stretching interventions, including slant board, towel stretching, and wall stretching, intended to elongate the posterior calf muscle tendon unit. But the type of stretching and duration needed to produce a clinically meaningful change in range of motion are unknown. Range of motion exercises are initiated in the acute and subacute phases of injury, but no evidence exists to suggest that one type of exercise is superior or even more beneficial for improving patient outcomes. Another clinical approach to improve dorsiflexion after ankle sprains involves joint mobilization techniques to improve arthrokinematics and osteokinematic motion. After an ankle sprain, posterior glide of the talus can be restricted and contribute to decreased dorsiflexion. Use of anterior or posterior joint mobilizations can improve dorsiflexion range of motion and gait. Mulligan proposed the concept of an anterior positional fault of the fibula after lateral ankle sprain. He suggests that during plantar flexion and inversion, tension from the anterior talofibular ligament can displace the fibula anteriorly. A strong correlation has been made between the amount of anterior positioning of the fibula and swelling. Management of positional faults with joint mobilization techniques and tape is gaining popularity, but further research is needed to clarify and substantiate the long and short-term benefits of these interventions. It has been proposed that the high rate of re-injury is in part caused by proprioceptive impairment that occurs following ankle sprain. Consequently, balance and sensory motor exercises have become an integral component of ankle rehabilitation and have been shown to effectively reduce ankle re-injury rates. Balance training is a near mandatory clinical intervention for athletes participating in high-risk activities such as basketball, soccer, volleyball, and football. Acute and subacute management of lateral ankle sprains focuses on decreasing pain, minimalizing swelling and secondary injury by using RICE, and in some cases, using non-steroidal anti-inflammatories. Functional rehabilitation is the treatment of choice for lateral ankle sprain and should include weight bearing as tolerated, range of motion exercises, strengthening, joint mobilization techniques, and sensory motor training as athletes transition into long-term management and return to function. Strength of recommendations for treatment are as follows. Cryotherapy should be applied to acute ankle sprains to reduce pain, minimize swelling, and decrease secondary injury. Compression should be applied to acute ankle sprains to minimize swelling. Elevation of the limb to minimize swelling. Non-steroidal anti-inflammatories to reduce pain and swelling and improve short-term function. Functional rehabilitation is more effective than immobilization in managing grade 1 and grade 2 sprains. Grade 3 sprains should be immobilized for at least 10 days. Electrical stimulation can be used as an adjunct to minimize swelling. Clinicians should refrain from thermotherapy during the acute and subacute phase of recovery due to the lack of evidence and the potential to exacerbate the injury. Cryokinetics can be used to reduce pain and thereby allow earlier rehabilitative exercises. Rehabilitation should include range of motion, flexibility, strengthening of the surrounding musculature. Balance training should be performed throughout rehabilitation to reduce re-injury rates. Passive joint mobilizations should be used to increase ankle dorsiflexion and improve function. After ankle injury, it is often difficult to determine when an athlete can return to full sport participation. Although range of motion, strength, and function are continually assessed during the rehabilitation process, it is also helpful to have quantifiable measures to assist with the decision-making process. Two such measures are patient self-reports and functional performance tests. When evaluating the effectiveness of any rehabilitation protocol, specific criteria are a vital component in injury management. Objective measures of function are a valuable part of this evaluation, but health-related quality of life assessments are equally important. In particular, patient self-reports can provide valuable information about an athlete's readiness to return to play. Over the years, various instruments have been developed, each designed to address either a particular condition or general lower leg or foot function. Several instruments have been tested in patients with ankle ligament injuries, and they include Foot and Ankle Disability Index, or FADI, Foot and Ankle Ability Measure, or FAAM, Foot and Ankle Outcome Score, Lower Extremity Function Test, or LEFS, Sports Ankle Rating System, Olerud Scoring Scale, the Ankle Function Scale, and the Kankkonen Functional Scale. The questions within the self-reports were designated to establish criteria which were established as important in the return to play process. The Foot and Ankle Disability Index, or FADI, was designed to identify functional limitations related to foot and ankle conditions. It has been used primarily in patients with chronic ankle instability, or CAI. It has two components. The main FADI, with 26 components, addresses activities of daily life, whereas the FADI Sport has 8 items and addresses more advanced tasks that are related to physical activity. Each item is scored 0 to 4. 0 is unable to do, 4 means there's no difficulty in doing something, and a higher score indicates a higher level of function. The FADI has been reported as reliable and sensitive in detecting injury and change. The Foot and Ankle Ability Measure, or FAAM, was born out of the FDAI and are nearly identical, except that 5 items have been removed from the FAAM after advanced psychometric testing was conducted. The Lower Extremity Functional Scale, or LEFS, is a questionnaire that includes 20 items, and each item is scored from 0, extremely difficult, to 4, with no difficulty. It allows patients to report their ability to perform a variety of tasks that range from daily activities, such as putting on shoes, to more advanced sport-specific tasks, such as running and hopping. The LEFS is a reliable and valid measure that is sensitive to change. Interestingly, this instrument does not ask questions that are specific to the ankle. However, it has been found to accurately report functional limitations in patients with acute inversion ankle sprains, while also being sensitive to change in patients recovering from ankle sprain. The other self-assessment tools are similar in that they attempt to quantify quality of life and functional ability. They all utilize a 4 to 5 point scoring system in order to calculate extent of disability. Each of the questionnaires provides an opportunity to gather additional information related to an athlete's readiness to return to play after ankle injury. No gold standard questionnaire has been globally agreed upon, so clinicians should evaluate each questionnaire and determine which is best for their population testing. Restoration of sport-specific skills was one criteria identified in the American College of Sports Medicine Return to Play Consensus Statement. Objective measurement of an athlete's ability to perform skills is conducted through functional performance testing. Athletes should perform a variety of functional tests, from plyometric exercise to single leg balance without pain or decreased performance, before beginning sport activity. Tests can progress from relatively simple tasks to more complex sport-specific tasks. Single leg balance, single toe raises to single leg hop test, or the STAR excursion balance test are all examples of functional tests that can be utilized for the ankle. All can be done without advanced laboratory or clinical equipment. Ideally, functional testing is conducted prior to injury and results are utilized for post-injury comparison. A myriad of more advanced single-limb hopping tasks have also been evaluated and are based on time or errors committed. Examples of these tests are single-leg hop for distance, triple crossover hop for distance, 6-minute hop for time, cross 6-minute hop for time, 6-minute shuttle run, single-leg hopping agility test, side hop and figure 8 hop test. One objective criterion that has been proposed to indicate readiness to return to play is 80% or better on performance on the functional hopping test compared with the uninjured limb. These functional tests can be utilized throughout the rehabilitation process, and they are particularly helpful when making return to play decisions. With objective measures to quantify progress during rehabilitation, the clinician has data to aid decision-making. However, none of these measures should be used independently. Each provides specific information on an athlete's readiness to return to play. Taping and bracing of the ankle are common practices in the athletic setting. Generally, taping and bracing are used prophylactically in effort to prevent first-time ankle sprain, or, more often, to prevent recurrent ankle sprains. A significant amount of research on taping and bracing has been conducted, but few authors have investigated if these measures can reduce the incidence of lateral ankle sprains. Taping and bracing both appear to be effective. Taping was shown to be more effective in those with a history of ankle sprains than in those without such a history. Bracing was noted to be more effective in reducing the incidence of ankle sprains in another study. Semi-rigid and lace-up ankle braces have been shown to be effective in reducing the incidence of ankle sprains. When the effectiveness of taping to bracing was specifically compared, the results were mixed. Taping was noted to be less effective than bracing, and in one study, bracing showed a 50% better reduction than taping. When the number needed to treat, or NNT, was determined to prevent a single ankle sprain, the NNT was significantly greater in athletes without a history of ankle sprain. A separate study evaluated the effectiveness of bracing and taping, concluded that athletes with a previous ankle sprain who had either braced or taped the ankle had approximately 70% fewer ankle injuries than athletes without prophylactic support. These studies prompted the question whether it is appropriate to prophylactically brace or tape entire teams regardless of injury history. Recent evidence from McGee et al. Suggests that bracing is effective and beneficial, even from a cost perspective in the long run. An additional issue that needs to be evaluated is whether bracing or taping the ankle has any negative effect on other joints in the lower extremity, specifically the knee. To date, bracing or taping the ankle does not seem to increase the prevalence of knee injuries. Due to very small sample sizes, definitive conclusions are difficult to make. Work on the role of footwear in the incidence of ankle injuries has been limited and produced conflicting results. One of the differences may be related to the type of athlete being studied. In basketball players, those with high-top shoes and taped ankles were more effective than low-top shoes and taped ankles. Conversely, football athletes with low-top shoes with ankle stabilizers were more effective in preventing injuries than in high-top shoes with ankle stabilizers. Type of rear foot cushioning may also contribute to the incidence of ankle sprains, but the literature on the topic conflicts as well. In one study, shoes with air cells were 4 times more likely to sustain an ankle injury than those players who did not have shoes with air cells. Spring-like rear foot cushioning was studied, and no difference was found in the prevalence of ankle sprain among different types of shoes. More research related to this topic should be conducted before a conclusion can be drawn regarding the role of footwear in the incidence of ankle sprains. Inclusion of the patient's perception of function should be considered in any return to play. Functional performance testing should be a component of return to play decision making. Athletes with a history of previous ankle sprains should wear prophylactic ankle supports in the form of ankle taping or bracing for all practices and games. Both lace-up and semi-rigid ankle braces and traditional ankle taping are effective in reducing the rate of recurrent ankle sprains in athletes. Prevention of orthopedic injury is a high priority for all athletic trainers and other healthcare professionals who work with athletes. Information is available for external ankle supports, but data on other forms of injury prevention are limited. The results of 2 recent prospective randomized control trials support the idea that supervised or unsupervised multi-intervention training reduced the risk of ankle injury by approximately 35% in athletes, especially court athletes. Other authors have offered similar positive findings. Although the evidence appears compelling, many questions remain. The number of ankle sprains was reduced when each of these training programs was used. However, the reason for the reduction is largely unknown. The duration, frequency, and length of training programs reported may range from 10 minutes to 1 hour per session, repeated 1 to 7 times per week, and performed 3 to 12 months. The optimal training protocol is still in question. There is no direct evidence to suggest that addressing range of motion or strength should be considered strategies to prevent ankle injury. Strength deficits and imbalances may play a role in vulnerable positioning of the foot relative to the center of mass during movement, adding to the risk of ankle injury. Clinicians working with athletes should implement a multi-intervention injury prevention program lasting at least 3 months that focuses on balance and neuromuscular control to reduce the risk of ankle injury. Addressing the strength of the leg muscles may be an ankle injury prevention strategy. Clinicians should consider assessing dorsiflexion range of motion in at-risk athletes. Ankle sprains that produce tenderness proximal to the ankle joint and do not show signs of fracture of diastasis are commonly referred to as syndesmotic or high ankle sprains. They are frequently seen in athletes and may be associated with chronic pain, prolonged functional disability, recurrent ankle sprains, and heterotropic ossification. They are generally caused by hyperpronation, consisting of external rotation, eversion, and abduction, hyperdorsiflexion or hyperplantar flexion, or another athlete falling onto a fixed ankle. Syndesmotic sprains can occur to athletes enduring chronic inversion and axial loading. Syndesmotic sprains account for 1 to 20% of ankle sprains, but the prevalence may be much higher and range from 40 to 74% of sprains. The primary role of the syndesmosis is to maintain congruency of the tibio-talar joint under physiological axial loading. With an intact syndesmosis, the fibula and tibia grip the talus much like an adjustable wrench grips a nut. If there is laxity of the syndesmosis, the gripping of the talus will not occur and the function will be impacted. Clinicians need a thorough understanding of the syndesmotic anatomy and biomechanics because recognizing proximal ankle injury can be difficult given the variability in severity and disability of high ankle sprains. Disability can range from days to months. Definitive clinical tests with which to grade severity and predict disability are lacking. Several clinical tests have been reported in the literature, including the squeeze test, modified Kliger test, fibular translation test, and cotton test, but none have been able to qualify the extent of injury. A positive squeeze test is less common, but associated with a prolonged recovery. A modified Kliger test has the greatest inter-tester agreement and the lowest rate of false positive results. However, it cannot identify the specific laxity or instability. When performing these tests, the clinician should look for provocation of pain that may be indicative of a syndesmotic sprain. Clinical tests should be compared with the results of functional and radiographic studies to better determine the injury. Classically, the patient will complain of difficulty pushing off or of lacking power when trying to regain normal function. The optimal imaging studies that should be used to identify the injury continue to be debated. Similarly, consensus is lacking as to how appropriately manage spasmodic injury, but most agree that early recognition and immobilization are important for appropriate care and recovery. Management focuses on protecting the injured structures, treating symptoms, and increasing range of motion, strength, and proprioceptive ability. For injuries that demonstrate frank or latent diastasis, may be best treated with surgical fixation. Chronic ankle instability, or CAI, is characterized by residual symptoms that include feelings of giving way and instability, as well as repeated ankle sprains, persistent weakness, pain during activity, and self-reported disability. CAI is believed to occur secondary to ankle sprain. Although most athletes return to full activity within 6 weeks of an ankle sprain, a large percentage, 4 to 74%, report residual symptoms, including loss of function, repeated injury, and disability. In one study, 74% of athletes reported at least one residual symptom up to 4 years after injury. Clinicians need to understand the potential link between CAI and ankle injury. Additionally, repetitive injury and other symptoms associated with CAI may lead to premature osteoarthritis. Two primary components of CAI are mechanical instability, including laxity, impaired arthrokinematics, and joint degeneration, and functional instability, which includes altered neuromuscular control, strength deficits, and deficient postural control. Several instruments have been developed to detect self-reported deficits associated with CAI. The Foot and Ankle Disability Index, the Foot and Ankle Ability Measure, and the Cumberland Ankle Instability Tool, or CAIT, are tools with published values for validity or reliability or both. They may be useful in identifying patients who are experiencing CAI. Specific deficits that characterize mechanical ankle instability and FADI include increased laxity, greater inversion motion and anterior glide of the talus, balance deficits, decreased dorsiflexion, and decreased plantar flexion peak torque. Other noted deficits include limited dorsiflexion, diminished hip abductor and extensor strength, postural control deficits, and altered movement strategies. These deficits are believed to contribute to functional limitations and disability experienced by patients with CAI. Patients with chronic ankle instability likely incorporate altered movement and protective strategies that predispose them to unprotected loads during functional movements. More data is needed to determine how each of these measured deficits contributes to the chronic nature of instability. Given the many deficits that have been linked to CAI, clinicians should focus their management efforts on restoring identified deficiencies while maintaining normal movement strategies. It has been reported that mobilization with movement techniques will enhance dorsiflexion range of motion in participants with a history of ankle sprains. Balance training, closed chain strengthening, and hopping have also been reported to decrease the repeat ankle sprains in those with CAI. More well-designed prospective studies are needed to determine if these intervention strategies have positive long-term outcomes for patients with CAI. For now, these strategies hold promise for reducing symptoms and risk. However, failed conservative management of CAI is still prevalent, and other interventions, like surgery, may be necessary to help restore stability. Syndesmotic ankle sprains are characterized by symptoms proximal to the talocrural joint and are associated with prolonged pain, recurrent ankle sprains, functional disability, and heterotopic ossification. Evaluation should consist of palpation, clinical testing, functional evaluation, and radiography with MRI if indicated. Syndesmotic ankle sprains should be treated more conservatively than lateral sprains. Acute management requires immobilization. Surgical fixation should be considered for syndesmotic sprains that demonstrate diastasis. Clinicians should be aware of characteristics that define chronic ankle instability. Several instruments may be used to identify patients with CAI and quantify severity of the condition. Mechanical and functional deficits in patients with CAI should be identified. Intervention strategies should address specific deficits in patients with CAI. Restoration of normal arthrokinematics, restored dorsiflexion may be beneficial. Strategies that focus on balance, strength, and dynamic movements with changes in direction may be effective in reducing risk of recurrent sprains in patients with CAI. The clinical management of ankle sprains in athletes should include comprehensive assessment and treatment plans based on the best published literature. Not all ankle sprains are alike, and it is important for each patient to have an individualized treatment plan. Because of high frequency of recurrent sprains, emphasis must be placed on preventing injury in addition to a safe return to athletic activities. Thank you for completing this course. For more information on Sport Safety International and other quality products offered, please visit us at sportsafety.org.